Hello, my name is Waterschoot. I'm an ENT resident at the University Hospitals of Leuven in Belgium, and today I would like to present our newest article about the surgical management of non-allergic rhinitis on behalf of the entire team. Non-allergic rhinitis affects roughly 1/3 of patients with persistent rhinitis, yet it remains underdiagnosed and undertreated. Patients get a diagnosis of non-allergic rhinitis if rhinological symptoms persist and no systemic sensitization to aeroallergens can be shown via specific IgE measurements or skin prick testing, and nasal endoscopy shows no signs of infection. Non-allergic rhinitis symptoms include nasal obstruction, rhinorrhea, sneezing, and nasal hyperreactivity, and they often coexist in varying degrees. Crucially, each surgical technique targets a different part of this spectrum. Inferior turbinate reduction addresses predominantly nasal obstruction, posterior nasal nerve interventions target rhinorrhea, sneezing, and hyperreactivity, and videoneurectomy is reserved for severe refractory rhinorrhea and hyperreactivity. A single technique rarely fits all. The decision pathway starts with at least 3 months of optimized medical therapy. When symptoms persist, the dominant symptom, obstruction versus rhinorrhea, determines which procedure is offered. Anatomical findings, objective measurements such as rhinomanometry, patient preference, and on-site available surgical tools and expertise all influence the choice. This paper provides a practical algorithm to structure that decision-making. Inferior turbinate reduction targets nasal obstruction. Non-mucosal sparing techniques like cold instruments and laser carry higher bleeding and crusting risk. Mucosa sparing techniques like radiofrequency, ablation, microdebrider, and medial flap turbinoplasty induce submucosal fibrosis while preserving surface epithelium and are preferred for their better safety profile. Videoneurectomy disrupts parasympathetic innervation by transecting the videon nerve. High success rates, up to 82%, but risk of dry eye and facial numbness limits use to carefully selected refractory cases. Posterior nasal nerve interventions selectively target nasal parasympathetic fibers while sparing lacrimal innervation. We have 3 options: cryotherapy, cold instrument neurectomy, and radiofrequency ablation. All 3 reduce rhinorrhea, sneezing, and congestion, with responder rates of 70 to 87% sustained up to 2 years. All of these techniques are described step by step in this article, with graphical and perioperative imaging included. Non-allergic rhinitis sits at the intersection of allergy and ENT. Successful management requires close collaboration between the allergist and the rhinologists. Referral notes should clearly specify the dominant symptom, prior therapy strides, and any anatomical concerns. Shared decision-making, weighing efficacy, safety, cost, and patient preference is not optional. It is a foundation of good care in this complex condition. Surgery in non-allergic rhinitis is not always curative. It aims for meaningful, sustained symptom relief. In some patients, post-operative medical therapy remains necessary, and structural changes after surgery may actually improve drug deposition and efficacy. Surgery and pharmacotherapy should be viewed as complementary strategies tailored to each patient's evolving symptom profile over time.